Hello, everyone. Thank you for joining us for today's webinar, Emergency Departments, A Front Door to Address the Opioid Epidemic. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar through two methods. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Marla Oros, will take questions at the end of the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1 PCB and/or NADAC credit, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you will receive several follow-up emails. The first will be an email with a link to the evaluation. The second will have information on how to access your certificate of attendance and continuing education credits through your MyIRETA account. We may send you an additional email to remind you of the evaluation. I'd also like to remind you that a recording of today's webinar, as well as a PDF of the slides, will be available on our website shortly after the presentation. I would now like to introduce you to today's presenter, Marla Oros. Marla Oros, RN, MS, and FAAN, is the founder and president of the Mosaic Group, a leading healthcare management consulting firm. Marla serves as a subject matter expert in the development and implementation of comprehensive care strategies critical to successful substance use treatment and integrative healthcare for medically underserved communities. She is a nurse with over 38 years of experience in community health, hospital administration, and behavioral health integration. Okay, Marla, if you're ready, I will pass things over to you.
Thanks, my fellow Marla, and good afternoon, everyone. Thank you so much for joining this afternoon's webinar, and thank you so much to IRETA for hosting this and giving me the opportunity to share with you the experience of Mosaic Group, a company that I have the pleasure of founding and leading, who has been doing work in emergency departments around the country since 2014. And so I'm really delighted to have the opportunity to share with you many of the lessons learned and some starting how-tos around working in emergency departments, because we truly believe that they are a critical door to addressing our high-risk substance use epidemic. And so in today's webinar, I'm going to cover 3 objectives. The first is to really level set for all of us, and I'm sure all of you agree that the emergency department is an important setting to be able to address opiate use disorders and this epidemic, or you wouldn't have joined us this afternoon. But I'm going to spend a little bit of time really defining a little bit more around why we believe that this setting is so important to integrate screening and interventions for opiate use disorder and to systematically integrate them. I don't want to skip over that word, because much of what you're going to hear about today is really about how to integrate interventions in a way that they become part of a routine part of care and become sustainable. And in doing that, we're going to think about some key considerations that emergency departments and those of you who are partners of hospitals, what are some of those key considerations that we need to think about in order to decide what types of interventions to consider and the conditions under which we might want to think about that, to both identify individuals with opiate use disorder as well as link them to care. And then for each of the options that we think about in terms of interventions. We're going to talk about some of the areas to consider when pondering which direction you would think about going. And I'm excited towards the end of the presentation to share with you Mosaic Group's Reverse the Cycle model, which really is a very robust, comprehensive approach to integrating many of the interventions that I'll talk about today as a case study for you to look at. So as all of us know, we continue to be plagued by this national public health crisis associated with substance use. And while COVID really has turned our attention as another major public health crisis, unfortunately, deaths associated with alcohol, drugs, as well as suicide, as most of you know, took the lives of a record 186,763 Americans in 2020, which was a 20% increase in the combined death rate and the highest number of substance misuse deaths ever recorded in a single year. This epidemic affects every state and is now driven largely by illicit fentanyl, fentanyl analogs. Methamphetamine is also now being seen in many deaths in many areas, as well as cocaine. And often it is the combination of these substances that is causing the steep rise in deaths. And according to the CDC, drug overdose continues to be the #1 cause of injury-related deaths in our country. When we look at this this graph, we can see that the steep increase between 2019 and 2020, which we know was pandemic related, but we can see that this is an epidemic that has been occurring for many years, and the rise in alcohol, drug, as well as suicide deaths over the many number of years to reach the record high that we had between 2019 and 2020. And of course, we know that the pandemic was such a significant contributor to this steep rise as a result of the anxiety, the stress, the disruption to many of our substance misuse recovery programs, despite the huge advantage that telehealth provided to us, the significant financial hardship that many individuals faced during the epidemic, as well as the impact on families, which contributed to the significant mental health, suicide, and of course, overdose deaths. And the cost of this epidemic is staggering. Substance misuse produces over $166 billion in healthcare costs. We know strains hospital capacity, and morbidity and mortality rates continue to rise. So we can't ignore that we have a significant issue. And as you know, you can't pick up a paper anymore, even with the pandemic, without reading about an issue around the substance use epidemic. However, despite this, what we know is drug and alcohol use treatment is inaccessible to many people, and only 1 in 10 individuals with a substance use disorder actually receive treatment. And this is the statistic that we are really honing in on in thinking about how do we find a different opportunity, a different door to help individuals who need help, because we know of the 21.7 million identified in need of treatment, only 2.35 actually reached that specialty facility. So we've got to figure out a better way other than relying on people taking that important step themselves and walking through that treatment door, of being able to offer that help to individuals. And the emergency department is that one critical door opportunity that we can use to begin to close that treatment gap. And we know that a multifaceted approach is needed to address the public health crisis that we are facing. Emergency departments are not going to solve the entire problem, but they are an important door that we know individuals are walking through. They're seeking help for their medical condition, and it gives us that opportunity to systematically identify individuals engaging in high-risk substance use and link them to care as appropriate. And so, as I introduced, emergency departments are really an essential access point in our healthcare system. And we know that effective emergency departments programs where we integrate behavioral health intervention can improve health outcomes for individuals with opiate use disorder. Individuals that come to our emergency department are asking for medical help. We have trusted individuals that nurses, physicians, and others that are in emergency departments, and it's an opportunity for us to be able to identify and offer that help. And we know that individuals with opiate use disorder and other substance use come to the hospital emergency department at a high level of frequency. And so they are coming through that doors, and we need to take that opportunity to be able to offer that help. Opiate-related emergency department visits increased by 112%, consistent with the epidemic, between 2010 and 2017. And research shows us that those who have experienced a non-fatal drug overdose are at increased risk for a fatal opiate overdose. So when that individual who presents to our emergency department and survives that overdose and leaves is at high risk for a subsequent fatal overdose. And so again, it's an opportunity not only to intervene with that patient, but to actually save their life. We also know that individuals with high-risk substance use have multiple chronic health conditions. Between 2011 to 2015, more than 90% of opiate-related hospitalizations were among persons with 2 or more chronic conditions. And the trend in opiate-related hospitalization among persons with multiple chronic diseases is increasing, as we can see from this statistic. And so individuals may not present directly with an overdose, the most severe opportunity to save that life that we just talked about, but we know that individuals with high-risk substance use are not attending regular healthcare appointments, they are neglecting their healthcare, and they are presenting to emergency departments with other chronic conditions, both associated with their high-risk substance use as well as other somatic healthcare concerns. We also know that 15 to 20% of individuals who visit an emergency department screen positive for a substance use disorder. And so we know that patients don't walk in the door necessarily asking for help. They may not present obviously with high-risk use, but if we can identify them, what you will see is that on average, 1 in 5 individual who walks through that door will screen positive for high-risk substance use. And when we think about trauma-related visits, that increases to between 25 to 50%. And so for all of these staggering statistics and for all of the opportunity that is presented through this opportunity, through this door that we've identified in terms of individuals who have these needs, the emergency department is in a unique position to intervene in identifying these individuals and offering them help. We can begin to normalize the conversation. This is a healthcare setting, and if we begin talking about drug and alcohol in a medical care setting, we begin to break down that stigma and normalize that talking about drugs and alcohol are part of healthcare, and we should be talking about that with healthcare professionals. We can build on the relationships that we know nurses and physicians and other healthcare providers in emergency departments have with their patients in a safe and confidential and accessible environment. We know that brief interventions based on solid research and data are proven to reduce or eliminate substance use and help individuals get into needed treatment. And so even if we don't have hours to spend, we know that even having those brief conversations can be incredibly helpful to reduce or eliminate substance use. And through the door that is already open to individuals presenting to the emergency department, we can quickly and easily screen and uncover the need for further assessment for substance use treatment. So let's get into the options for consideration to use this critical door, the emergency department, as a setting for intervention. And so there are a number of principles that I want to lay out to describe for you before we get into the menu of options for consideration. And so the first one is that we really believe that the goal of integrating whatever option is identified is to really integrate it into the health system as a routine part of care. And so much of the considerations and discussion that I'm going to share with you today around this menu is focused on the different ways and considerations to think about how to not have these interventions just be an add-on, but how do we really leave that emergency department in a different place so that they truly integrate interventions as part of what they do, as part of their scope of what they offer. We also know that there's an opportunity to align this with overall population health goals. If individuals present with high-risk use, have 2 or more chronic health conditions, we have an opportunity to impact hospital reduction in readmissions, which we know is connected to individuals with 2 or more chronic conditions. And so the comorbidity of behavioral health with chronic health is clear and therefore an opportunity to impact what hospitals care about, which is reduction in readmission, along with focusing on improving health outcomes. We know that organizational culture and leadership buy-in is really at the heart and soul of what is essential to initiate, plan, develop, implement, and sustain emergency department interventions if our goal is truly practice adoption. Any system change, as all of us know, really requires leadership to support this and buy into this. And much of what we think about when we are proposing the integration of behavioral health interventions is new. It's different. It's not what emergency departments and many of the providers who work in our hospital think it may be part of what they were trained to do, what they should be doing, or what they are tasked to do. And so adopting these interventions and truly integrating them for sustainability requires buy-in at multiple levels, starting with the top, and really over time requires the organization to shift its culture to and the way that they think about treating individuals with substance use disorders. The tool of the electronic health record, as all of us know, is absolutely essential if we are going to achieve any level of practice adoption. And so much of what we see in efforts to integrate behavioral health interventions are the inability to be able to modify and work with electronic health records. I am here to tell you, while it is very challenging and it is difficult, it can be done. In the over 70 hospitals that Mosaic Group works with nationally, we have been successful in integrating all of the documentation and data collection required for the behavioral health interventions. And we know this is important because the tool is essential to support alignment with workflow and for the ongoing and systematic integration of these interventions so that they occur on a consistent and regular basis aligned with the workflow of that emergency department. Staff capacity and training is an area that you're going to hear me talk about over and over again. That's absolutely essential that we understand that this is something new. There's new work and interventions that are required. There's new competencies that are required. And as a result, we need to consider what's available, what staff are available, what they're willing to do, and what type of training they need. Outcome measurement and monitoring is an essential part of what Mosaic Group thinks about from the beginning when we work with hospital emergency departments, and something that is important to be able to track interventions so that we can all see whether or not they are achieving the goals that we set out to, and we can use it from a good quality improvement perspective to modify protocols and interventions based on a data-driven approach. And finally, all of this is really with the eye for sustainability. If we really start with an eye towards systematic integration and true practice adoption, that these interventions should become a routine part of care, then we need to be thinking about how do we sustain these programs long term. And some of these questions are difficult to answer. Sometimes we don't always have the answers, and that's okay. That should not prevent us from starting, because we may need to show success, demonstrate that these programs are effective, and then begin to really think about long-term sustainability and what that will look like. So the menu that I'm going to talk about with all of you today are universal screening, and what does that mean? The interventions for high-risk patients, meaning the staff that are going to respond to the patients who present that screen positive. Peer recovery coaches are an option to think about. It's certainly something that we are seeing a lot of dissemination in practice, which is terrific in terms of the integration of this critically important workforce into emergency departments. We're going to talk specifically about the emergency department as a setting for rapid response for opiate using patients, and especially overdose patients. We're going to spend some time thinking about the integration of MOUD, which all of us know is now the standard of care for the treatment of opiate use disorder, as well as considerations for linking patients to care after discharge from the ED. So when we think about universal screening, we really think that this is a fundamental, foundational first step to be able to close that treatment gap. Because we know that many patients, as we've already spent time, are presenting to emergency departments and aren't obvious to us. They're not significantly intoxicated. They may not be the overdose patient. They may not be presenting with significant symptoms of their substance use. They may be presenting with those other medical conditions. And so we need, in order to really use that emergency department as the door that we want to take advantage of, we need to screen everybody. If we're going to normalize this as part of healthcare, we need to normalize asking questions about use as part of that emergency department visit. And if we can ask everybody, we can close the gap and begin to really identify those individuals that need help. And the way that we do this when we think about universal screening is really to use the validated screening tools that are available to us to be able to assess opiate use, alcohol use, prescription drug misuse, overdose, other illicit substance use, and intoxication. And so the considerations when we're thinking about this important foundational intervention is, what is the capacity to respond? And I can tell you that in every hospital emergency department that we work in, big, small, suburban, urban, rural, nurses always say, we don't have time to do this. And so we need to be able to think about how to respond to that in a way that allows us to be able to still get that done. And that gets to the tool selection. There are many, many tools that we can use for universal screening. And so when we have capacity issues, then we need to think about shorter tools that can get us to the same goal. And we may need to narrow what we're screening for. And so deciding the patient population that you want to focus on, as you can see, we just talked about a variety of options in terms of the patient population. Do we only want to screen for opiate use and focus on that? Do we want to screen only for systematic identification of overdoses? Do we want to look at polyaddiction? So any illicit substance use, including opiates? Do we want to include alcohol as well as intoxication? And so thinking about the patient population, adults or kids, or both, that you want to focus on is going to help us understand which tool we need to use, and it will also help us be able to communicate to nurses or others who may do the screening what the time commitment that it would take to be able to do this. Understanding some of those population health goals may also be an important factor in thinking about the tool selection and who you want to focus on. If we are really understanding that individuals that are presenting with not only opiate use are a priority, but many hospitals see that alcohol use is impacting readmission. It's a significant comorbidity associated with other chronic health conditions. And so understanding the hospital's overall population goals is important when thinking about the focus of this. Leadership and staff buy-in is really critical. Conducting universal screening, if we're going to ask every patient that presents, is a change. And so again, getting that emergency department nursing director, medical director, your VP of patient care services on board with this is absolutely critical to start the process, but it's going to be critical to implementation as you launch and want to assure there's fidelity to the screening and it truly is integrated and implemented on a consistent basis. And finally, as we just described, incorporating the screening tools into the electronic health record are very important in order for us to be able to assure that it happens, and it happens in a universal and consistent way. So once we screen, we need to intervene. And so thinking about who is going to do that is really an important first step in understanding what you want to, how you want to build your program. And so when we think about this intervention, we're really thinking about this in a different way. We know that now in emergency departments, we may ask some routine questions. Do you drink? Do you use drugs? And we have a social worker, a case manager, or somebody on the behavioral health team who, if available, can speak to a patient. When we're really trying to have a more targeted intervention in response to the screening, then we're really trying to think about what kind of dedicated staff can you put in place to, again, more systematically respond to those patients who you've identified as high risk from the screening process. And this is very important because a program will fail if we convince our hospital partners to do screening and we ask the questions and we get them on board to ask the questions, and then we don't have a system in place to then help those patients who we've identified as high risk. And so a barrier frequently is, why do I ask if we can't give the help? So being able to dedicate staff who can systematically respond is really at the heart and soul of what we're talking about in this intervention. And we're really also thinking about this in a way that is very patient-centered, and that usually involves applying techniques of motivational interviewing, which we know is a evidence-based practice that uses communication and techniques and tools to really understand how the patient feels about their use. And so typically what we do right now is we understand that patients who screen positive are using, and we assume that we should just refer them to treatment and give them a list of resources. If we're having a more patient-centered approach, then our first step is to really understand, how does that patient feel about their use? Where are they in their journey of thinking about making a change? And focusing the intervention on where that patient sees their use. And that may be, I'm not ready for treatment today, but I'm willing to reduce my risk, and I need some other recovery support services. Or it may be, I really am ready to take that step, and we need to help that patient move on to care. And the range of those options in our intervention are really what we are focused on in the conversation that we have when we intervene with these patients. So thinking about how to adopt this intervention, we need to think about the availability of staff and who's going to respond to that screening, being able to have the right skill set to engage with patients in the patient-centered manner in which I just described. The schedule and coverage of available staff, really thinking about the high need patient population. What do we think could be a projected volume? What are the busiest times of the hospital? And making sure that we can plan for covering the emergency department so that we're able to respond to those patients when we know that the busiest times are when they may screen positive. Rapid response for opiate using patients is a more specialized intervention that I'm going to speak to in a moment. And then, of course, using peer recovery coaches is a very highly specialized way to ensure the patient-centered approach and to intervene. And so peer recovery coaches, as most of us know now, since they have really become a very important part of the workforce in our work to try to intervene with high-risk patients with high-risk use, are those individuals who actually bring that lived experience of recovery combined with training and good supervision to be able to be that person who is going to come in the emergency department and have that conversation with the patient. And we believe very much in the use of peer recovery coaches in our Mosaic group model. Peer recovery coaches are really the essential frontline staff that are doing the interventions that we just described from our screening, because we know that patients engage with individuals who can say, I've walked in your shoes, in a way that nurses like myself, other providers or social workers, as patient-centered as we are, may not be able to have that connection. And so peers are really important. Peers can provide a lot of value, but they also require a lot of additional considerations to think about when we think about the use of this critical workforce. The first is these are new staff. So if we're thinking that we want to add peer recovery coaches to our intervention, then of course we need to figure out how we're a funding stream to be able to support bringing those individuals on. Training is really, really essential, and there are many training programs, well-known training programs out there in the community to train peer recovery coaches. Many of them provide the essential core competencies for peer coaching. But what's different about peer recovery coaches in an emergency department is that they're delivering what Mosaic Group calls front-end coaching. And so we've seen a lot of peers who work with patients on their recovery journey once they've made the decision for treatment and they're in a treatment program and the peer is part of that team supporting that patient in their journey for recovery. However, in an emergency department, we have a patient who may not be ready, who hasn't made that decision. And so the role of the peer isn't supporting them in their recovery journey. The role of that peer is really to have a conversation focused on understanding where the patient is in their thinking about their use in that moment when they are in the emergency room or in the hospital if they get admitted. And so while they need all of those critical core competencies that we know are essential to all peer recovery coaches, they also need additional specialized training on how to do that level of front-end coaching, as well as how to be in a very busy, multidisciplinary, highly stressful emergency department, and working both within that kind of setting, but also working with the multidisciplinary team of physicians, nurses, other providers that are part of an emergency department setting. And so training is critical to the success of thinking about integrating these peer coaches. Recruitment is also something that is obviously important if we're going to hire new staff, but when we're hiring staff into a hospital, depending on whether we are making these peers employees or we're partnering with community partners to place them, we know that hospitals have very specific requirements around being able to work in the healthcare setting, as well as being able to document in an electronic health record, view an electronic health record. And so thinking about all of those different aspects in the recruitment process is really going to be important to the long-term success in using this workforce. And then finally, supervision is something that is really essential to the long-term success of working with peers. These individuals are essential, they're important, they have a tremendous amount of assets and skills that they bring to us, but they also, in many cases, are paraprofessionals. In many cases, this may be their first job that they've actually had since they've been in recovery. And so having the right type of supervision that can support their continued growth, professional development, their own sense of being able to stay in recovery and supporting their own self-care is really, really important to think about when we think about integrating peer recovery coaches. I want to spend a moment talking about rapid response for overdose patients. This is something that is really critical and a place where many emergency departments start because it is the most critical, highest risk patient population to be able to intervene. And so when we think about patients who present with overdoses, there are a number of things that could be offered to that patient when they present to that emergency department. And one is obviously medical stabilization in the field. But it's also being able to immediately, and this is why we couched it as rapid response, provide that harm reduction support to that patient, that survivor who presents, because we know that these individuals who present to emergency departments are coming in from the field. They're usually transported by EMS. They've been Narcaned in the field and require medical stabilization, but when they wake up, when they are more stable, we know that they are not terribly happy, and they generally want to leave the emergency department as quickly as possible. And so the response really does need to be highly prioritized because we don't usually have a lot of time to be able to support that patient. And it's a critical time to intervene for harm reduction purposes, because as we talked about in the beginning of this webinar, we know that individuals who present and have a non-fatal overdose are really at high risk for having another overdose that could be the fatal overdose. And so we want to get to that patient quickly. We want to do some very good harm reduction education with that patient about that risk, letting them know that they are opiate naive, having been given Narcan, and they're at high risk when they use in the community again for subsequent overdose. We want to think about getting them a Narcan kit, preferably, or at least a Narcan prescription. And then we want to really, really focus our intervention on making sure that we can make a referral to community recovery peer support to support that patient so that we can prevent that overdose from happening again and hopefully prevent that patient from dying. And so thinking about this critical intervention is really, first, we need to have good community partnerships. What's the availability in the community for that community level support? While this intervention is about stabilization and harm reduction in the ED, we're going to save the life when we provide that patient with that support in the community once they leave. So who can we establish that partnership with to be able to make that direct referral? How can we have a peer in the emergency department who can do that rapid response and intervene? We know that from effective models, both our overdose survivor outreach program, the relay model, and others, that having peers do that initial intervention in the ED as well as the follow-up is really very, very, very helpful and makes a difference. Thinking about that protocol for naloxone, do we have kits that we can make available? Do we have prescriptions? What's the regulatory environment in terms of how to dispense kits, writing prescriptions? Who needs to do the training? All of that needs to be thought about in being able to dispense that critical Narcan, either through a kit, again, or a prescription, who does the training, and being able to support these overdose survivors. MOUD integration is really has become a sentinel part of emergency department interventions because, as we now know, medications for the treatment of opiate use disorder really has become the standard of care for the treatment of opiate use disorder, and we know does save lives. As soon as we start an individual on a medication that will treat opiate use disorder. And so there's a range of options to think about for MOUD integration. The first is initiating medication in the emergency department, which means actually giving a patient before they're discharged medication so that we are bridging them essentially without giving them that prescription. We're essentially having them leave the emergency department with medication in their system. We've given them that medication so that they don't get sick when they leave, and we can prevent them from going into withdrawal so that they show up for treatment. And so initiating patients helps to be able to stabilize them when they're in the emergency department, as well as support their linkage to care when they leave. That can be also supplemented with bridge prescribing. So we can initiate a patient, we can start them on the medication, but we can also have them leave with a bridge prescription so that they can continue on the medication until they can get to treatment, hence bridging them. And then we can have a very more robust response, which is actually treating patients with opiate use disorder and treating them as we would any other condition for their withdrawal, regardless of whether the patient is going to treatment or not. And so putting those clinical order sets in place so that as soon as a patient presents with opiate use disorder, we are starting them on medication to respond to their withdrawal symptoms. And so there are many considerations to think about here. The first and foremost is, how do the physicians feel about this? And we know that there's a lot of differing perspectives among the medical community around the use of medications. And so obviously having that buy-in of clinical leadership is absolutely critical. The availability of providers who are waivered are something to consider if we're thinking about bridge prescribing. Initiation is doable using the 3-day rule. We can initiate individuals in the emergency department using that 3-day rule that allows non-waivered providers to do that. But if we're going to move to bridge prescribing, we need to have waivered providers. And then the availability in the community for MOUD ongoing treatment and being able to make those referrals. And if we're only giving individuals 1 dose of medication before they leave, we know that that means we need to get patients to treatment quickly, or what Mosaic group calls fast tracking them to treatment. And so being able to develop those partnerships may be an important part depending on where you want to, what option you want to choose in MOUD integration. Clinical expertise to develop the order sets to, again, support that practice adoption, being able to train your providers once you make a selection in the direction you're going, and then being able to identify the patients. This is really something we don't often think about, but once we put the system in place, then we can't often rely on the medical providers or nurses to be able to identify which patients are appropriate for consideration and clinical evaluation. And again, this is where that screening and that intervention is that foundation for being able to identify which patients are interested in treatment, to then be able to refer to providers to be evaluated for medication. And then our final option is really linkage to care. This is really what a lot of people think is at the heart and soul of the intervention. It really is obviously so critical. It's not the only thing, as hopefully we've shared today, that we can do, because there are a range of things that we can do. But linkage to care, in the way that we think about this, is really doing highly supported warm handoffs to treatment, so that we are really, as we say to our peers, doing anything and everything that we need to do to support that patient moving on to connect to the treatment program and the other critical recovery support services that they need to impact their health. And so to think about this, again, this takes time. It takes more time to, then give to help make those appointments, address those barriers, than just giving the piece of paper, having the coverage. Again, we talked about that, when we need to be able to support patients, having the partnerships in the community to be able to actually give an appointment to a patient, help them make an appointment, versus just having them call the 800 or your state's hotline to be able to see what's available. And really tailoring that treatment to the patient's substance use. every treatment program, inpatient, outpatient, is not the same and isn't appropriate for every patient. And so really being able to understand and have the range of treatment programs available and being able to understand the matching of what makes sense depending on that patient, their use, and what we think is the most clinically appropriate option for them in that discussion with the patient is really important to have good linkages to care to assure success. Being able to have that warm handoff, addressing those barriers, which means a lot of times having transportation and other systems in place that will support that successful linkage. So I want to share with you in our last couple of minutes a little case study of our reverse the cycle model, which includes most of the components we talked to here today. It includes universal screening, peer intervention, dedicated linkage to care warm handoffs. It includes a community overdose response, as well as the rapid response in the ED and MOUD initiation. And so I want to turn it over to Marla, who I think is going to help us watch a little bit about many of the interventions we saw today happening at our partner, Greater Baltimore Medical Center in Baltimore County, Maryland.
Yep, here is the video. All right, Marla, did you have any other slides you wanted to share? Because I can make you presenter again if you did.
Want to my contact information?
Okay, yeah, someone had asked for that too. So I'm going to make you presenter again so you can share that.
So let me just end with first letting you know that the peer in that photo, Latanya, now works for us. The GBMC program continues to exist. It's been expanded. They now have what we call Project Heart, our program for the mother-baby program, the mother-baby patient population, as well as they've integrated SFIRT. That was a question I saw. This is SFIRT, as you can see, the core intervention in all of their ambulatory care practices that are owned by the hospital as well. So it's been very successful. So key takeaways, guys: integration, it's essential. Leadership buy-in is important. Practice adoption is the way we want to go. One size doesn't fit all, really understanding the workflows and how this works. It's critical to establish outcome measures during the planning process. Training is really important to this, and really having the time to plan and the expertise to be able to do this well is really important, because this is new stuff. And so to have it tick in the way that you just saw really requires a lot of good planning and implementation expertise. And so don't underestimate the importance of that. So thank you, and I'd love to entertain in our couple of minutes left questions, please feel free to reach out to me by phone or email.
Did you want to share your, I'm not seeing your slides.
Oh, sorry.
No, that's okay.
So,
because someone did ask about contact information.
Yeah.
So I just want to make sure.
Yep.
Okay, there we go. But yeah, she said that she's working on trying to collaborate with emergency departments in Pennsylvania to encourage initiation of MOUD prior to discharge. And this presentation was great. And she thanks you.
Great.
One other question that you didn't address, someone said, I am concerned for the amount of drug education our ED doctors are mandated to attend. Is it true that doctors only need 8 hours of education in drugs and alcohol?
So I think the 8 hours maybe that is being referenced is the waiver program, the training required to get a waiver. And so I'm not sure. Some states have integrated. I think Maryland does have a now requirement, a CME requirement related to substance use, but that varies by state. But the waiver requirement, as most of you know, has been changed to expand access. So they now have, if a provider is willing to prescribe medications for opiate use disorder and maintain a panel of patients under 30, they do not need to take the required 8-hour course. They simply need to submit on SAMHSA's website a notice of intent to prescribe. It's a simple application, and they then will be sent that waiver without having to take that 8-hour course. And so emergency room providers are really prime for this, because they generally don't have regular patient panels. And so it's really a significant opportunity to increase the number of waiver providers that give us that opportunity for bridge prescribing.
Awesome. And then one other question just came in. Someone asked, any suggestions for retaining recovery coaches in emergency rooms, funding strategies?
Funding strategies, that's a great question. I think it depends on the state. So exploring whether your state has any Medicaid reimbursement or any reimbursement, and what those requirements are is one thing to consider. Many of the places we work with do not. And so, there's, a lot of grant funding available from federal programs now to seed fund programs, start programs. And then I think, we've been very blessed and successful at having our hospitals see the value through the data that we show in terms of the number of patients that are able to have the intervention, how many patients actually get linked to treatment, and we're now really linking that to demonstrate return on investment with the reduction in readmissions and as well as in terms of their high-risk patient population. And so I think, really having that data and, working with hospitals to understand, what matters to them in terms of being able to fund some of this is, I think, something that it is doable. I will say it's doable. We've been able to have that happen with our hospital partners based on the demonstrated outcomes and success of the program.
All right. Well, that wraps up the questions that came in. We had a lot of comments coming in just thanking you for a great presentation. I too would like to thank you for a great presentation, and I just have a few more housekeeping things to take care of here. Let's see. We would like to remind all participants that a PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IRETA's website sometime next week. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation, and the second email will include step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check your attendance records in our system. We would like to specifically request that you fill out our evaluation. It should take no longer than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate in this webinar. And again, we'd like to thank Marla Oros for this great presentation. If you have any questions at all, please email us. The email address is info@ireta.org. And with that, I will conclude today's webinar. And thanks so much again, Marla. Have a great day, everyone.